Hello and good evening, friends. Today is the fifth talk in the master series of the ACNS webinars for the month of August. And today we are going to discuss a very special topic. As you all know, 3 to 5% of the general population have unruptured brain aneurysms, of which some may not rupture at all during their lifetime. But in case if it does, then nearly 30% of them may have a fatal outcome. There is no doubt that aneurysms more than 7 millimeters should be intervened in the form of clipping or coiling. But there is a lot of difference of opinion on what constitutes the best strategy for small and medium-sized aneurysms. There are many clinical risk assessment scores to calculate the risk of rupture and guide the treatment. But the newer imaging techniques and their ability to assess instability in unruptured aneurysms have created a new window of opportunity in planning and management of unruptured aneurysms. The speaker for today is an active researcher in unruptured aneurysms and has contributed several manuscripts in this field of imaging technique, otherwise known as high-resolution vessel wall imaging. Ladies and gentlemen, may I please introduce you to the Chief of Vascular Section, Department of Neurosurgery, Professor David Hasan, from the University of Iowa, United States of America. Professor David started his long career in vascular neurosurgery with his fellowships with legends like Professor Juha Harnes-Niemi and Professor Spetzler. He was also an endovascular fellow at the Thomas Jefferson University and the Virginia University. Professor David mainly looks after the cerebrovascular neurosurgery and in addition runs a lab which is involved in the research of molecular mechanisms of aneurysms. He was the first to propose and provide evidence that there is a potential and effective role of medical treatment, that is aspirin, in decreasing inflammation in aneurysm wall and decrease the risk of aneurysm rupture in human and animal studies. He has several publications to his credits, most of which you might have read in the ResearchGate link I shared with you on our social media pages. To chair this session today, we have with us Professor Hidehito Kimura from the Department of Neurosurgery, Kobe University Graduate School of Medicine, Japan. Professor Kimura is an active researcher in imaging of unruptured aneurysms. He has also published his findings on hemodynamic characteristics in growing aneurysms as well as detection of thin-walled regions in aneurysms by computational fluid dynamics. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, it's my great honor to welcome the speaker, Professor David Hasan, and the chair, Professor Kimura, to this online platform of ACNS webinars. And with that, may I please request Professor David Hasan to start his talk.
Good evening, everybody. It's my pleasure to join you today and share with you some of my thoughts and our work that is ongoing, if you will, for using imaging techniques to predict which aneurysms are stable or unstable. As this has been a journey and it's an evolution, if you will, from the time I joined our University of Iowa approximately 11 years ago. And that evolution has been progressive and getting better and better. And it's a teamwork. It's not just our group, but different groups from around the world helping and participating to improve this technique. So again, this is an evolution, if you will, of our understanding of aneurysm wall imaging. We have different techniques. The first one, as I mentioned, is the femoxytal enhanced MRI. And as you see here, these are different aneurysms that we image with femoxytal. And as I mentioned earlier, that femoxytal is nanoparticles, is taken only by macrophages. And we use two different doses and different time points, immediately 24 hours, 72 hours, 120 hours. And we found out the best dose and the best timing for imaging these aneurysms. And this is our different, if you will, aneurysms that were imaged with femoxytal. And you could see here that wall have hyperintensity signal. And when we did aneurysm clipping and collected the tissue, we saw those nanoparticles residing within the macrophages and therefore highlighting that these images depict the pathology within the aneurysm wall. The next technique we use is the QSM, which is a quantitative susceptibility mapping. And it's based on two phases, the magnitude and the phase. And when you combine them together, and as you see here, you can able to depict the iron, if you will. This is a patient, the first patient we imaged. She's a 75-year-old female, presented with typical sentinel headache, CT was negative, lumbar puncture was negative. So we decided to use the QSM, and we were able to see, if you will, this microbleed at the interface between the aneurysm wall and the brain tissue. So with that, we did several studies, and we confirmed that this is a true presentation of microbleeds. And this is a histology, if you will. You could see here the hemosiderin at the interface, the outside wall of the aneurysm wall and the brain tissue. So we did further validation to see if this is correlation. And what we did is we took in vitro, we put different concentration of femoxytil, and we imaged them with the QSM and quantified the signal, and with the correlated with the concentration of the femoxytil. And you could see here, if you will, there's a very linear relationship. So we found with that you could absolutely depict with accuracy, 100% accuracy, the microbleed at the interface. However, there's a limitation. And the limitation here is that anything close to the bone or the air, it creates an artifact. So from that, we found out you can only image approximately 60% of all aneurysms with a QSM, which is a major limitation, if you will. So that's with the QSM. Now, we wanted to improve that technique. So what we did is we looked in the literature, and in the last 3-4 years, we've been focusing on high resolution vessel wall imaging. So we wanted to correlate the QSM with high resolution vessel wall imaging. And as all of you know, this was started approximately in 2013 and 2015, or 14, if you will, both by Matuk, El Jadali, and Professor Nagata. They all promoted that, and what they started their work is the aneurysms that rupture, when you do the black blood, or if you will, the vessel wall imaging, you could see some enhancement of the wall. And there was, because of that, a suggestion that this could present an imaging of inflammation. So we wanted to correlate. This is again another figure where if a patient presented with 2 aneurysms, this is from Matuk, you could tell which one aneurysm ruptured versus non-ruptured, and you can kind of tailor the treatment accordingly. This is another patient, if you will, presented the night. In the evening, we got a vessel wall imaging, and we were in to get the pipeline device. And the next morning it ruptured, and you could see the enhancement right here of the vessel wall before the rupture. So it's somehow, it can predict, if you will, which aneurysm is going to rupture or not. So to compare QSM to vessel wall imaging, and because again, QSM has a lot of limitation. Specifically, it only can be used in 60% of the aneurysms due to the air and artifact. But vessel wall imaging, you can use it for a lot of aneurysms. So what we did is we did a prospective study, and we created a protocol. So all our patients, irrespective whether they are ruptured or unruptured, they come in and they have this protocol, MRA with gadolinium, QSM, vessel wall imaging. We use a 3T machine, and then we have 2 neuroradiologists kind of help with adjudication. This protocol takes about 30 minutes, if you will. And what we did is we accepted that microbleed be quantified as greater than or equal to 0.1 parts per million. So the positive QSM, if you will, it has to be that threshold. It have to be above that threshold. And the same thing for the vessel wall imaging. We did not rely on just visualization. People say, well, it's partially enhanced, focal enhanced, circumferential enhanced. We don't. We usually use the stock ratio, which is take the signal intensity in the wall divided by the signal intensity in the pituitary stalk, and we came up with the cutoff of 0.5. So anything above 0.5, and I will explain to you later why we use it as a positive of indication and that this vessel wall is enhancing. This is a patient where had a distal MCA, if you will, and you could see on the left panel is enhancing wall. On the correction, and this is more of QSM, positive QSM, and then on the other side is the positive enhancement on the vessel wall imaging.
Here we see on the left is the QSM.
And so here we did 73 consecutive patients with 88 unruptured aneurysms. 8 patients with 11 unruptured were excluded. 26 of the 70 aneurysm could not be visualized, again, because of the QSM. And there was about total of 40 patients were included. And all of the 40 patients, they have 51 unruptured aneurysms. The average size was about, average age was 62 years old. The diameter was about 7.3 millimeter. And you could see here about 88% of the aneurysm were saccular and the 12 were fusiform. And this is the demographics among these ones. But what we found out here, that QSM was specific 100% and has positive predictive value of depicting sentinel headache. And so we accepted that as a ground truth. However, the sensitivity is low, as I mentioned to you, and that's because the limitation due to the artifact. Now, if you take the vessel wall imaging and correlate it with the QSM, you could see here that the vessel wall imaging is 92% sensitive and almost 97% have negative predictive value. Meaning, if the vessel wall does not enhance, then the aneurysm did not have microbleed and hence was stable. And this, what the figure or the table that we use currently, it's a paradigm treatment and based on both the QSM and the vessel wall imaging. So if it's QSM detectable or non-detectable, if it's detectable, it could be positive or negative based on the cutoff, 0.1 parts per million. And the enhancement is based on the stock ratio, present or absent. So if you could see here, the QSM is positive and the enhancement is positive, these are unruptured, then we strongly recommend treatment. If QSM is negative and the enhancement is present, we consider, we depends on the patient and the surgeon, we say consider surgery. If it's QSM is negative and the enhancement is absent, we strongly recommend conservative management. So what does the enhancement of the aneurysm wall mean? A lot of people suggested it could be inflammation. So what we did is we took 10 subjects. We had 5 of them was completely the wall enhanced and 5 did not enhance. And we clipped them and collected the tissue. And you could see here, this is one is ICA terminus aneurysm, did not enhance. It was clipped and you can see here the immunostaining. Here in the intra procedure, you could see here the top panel after the clip applied, the second panel after the aneurysm was clipped, resected, or partially resected, if you will, the dome. And this is another one that MCA, it's avidly enhanced. You could see at the base on panel C that there is a blister or like a daughter sac at the base. And D shows the immunostaining. And here after the clipping is done and the dome was resected, you could see here that the tissue, there's a lot of atherosclerosis noted inside the wall. So what we compared both aneurysm and we found out that the ones enhanced, they're thicker wall compared to non-enhanced, but also they have tons of CD68, which is macrophages. So we suggested, and others kind of confirmed that from our Japanese group, that the enhancement correlate to neointimal hyperplasia, atherosclerotic layer with inflammation, and possibly vasovasorum. So the next thing is we wanted to know if that gadolinium particles actually diffuse inside the wall, not just at the interface, but does go inside the wall and hence that gives you that enhancement. This is a control tissue. You could see here if the gadolinium is within the tissue. You could see on the spectroscopy, electron microscopy, that you can pick up little peak of gadolinium. So we used that control tissue and we did our aneurysm wall. We did about 7 aneurysm walls that enhanced with gadolinium. And we did the electron microscopy to see if there's gadolinium within the tissue of the wall. And unfortunately, we did not see. So that in itself gave us the idea that the enhancement has a different meaning. It's not within the aneurysm wall, it's the interface. And I'll go over it in a little bit. So the next thing is, again, everybody start publishing on this topic. And what I consider enhancement, other person does not consider that as an enhancement. What do I consider as focal enhancement? Someone would consider it as circumferential enhancement. So what we try to do is try to objectify the measurement. So when I tell Raja in India that I have an aneurysm that enhances that 0.6, see, we immediately understand that and it's objectified and can reproduce. So there are 3 ratios that created by one Omodaka, 2 of them by Omodaka, and all these ratios suggested the possibility of using them as an objective measurement of the aneurysm wall. The first one is the aneurysm enhancement ratio, then the aneurysm enhancement index, and the last but not least is this, the stock, the pituitary stock ratio, which we use. So what we did is we had 102 aneurysms in 80 patients. We collected them prospectively. And we collected all the demographics, if you will. And then we did under the curve to see which one is the best in correlating to unstable aneurysm. And what you accepted as unstable aneurysm is here, the ground truth is the size. So if aneurysm greater than 7 millimeter, we accepted that as a ground truth of increased risk of rupture. Anyone that's below 7 millimeter is decreased. And when we did that, the specificity and sensitivity, we found out that the stock is much better than the other 2 ratios. We used the mean signal intensity, which means we collected 4 different points in 4 different quadrants in the aneurysm and averaged that. And then the second one we use is the maximum signal intensity. From the 4 quadrant, we use the highest signal intensity and we used it. And from all that, we found out that the best predictor for aneurysm instability is the pituitary stalk. And we use the maximal signal intensity. And you could see here the sensitivity was approximately 82%. And as I mentioned to you, you accepted the aneurysm of greater than 7 millimeter as the ground truth for unstable. Now, validation. Now, if I use an MRI in my institution, let's say a Siemens, and again, Raja uses GE, can the signal intensity, the number I created or measured from the C-stock is the same thing on my machine as is in India, using a different like Philips or things. So what we did, we took 5 patients, and those 5 patients had aneurysms, and we imaged them 6 weeks apart, one with a 3T Siemens, the other one with 3T GE MRI, and then we calculated the ratios and that. And this is what we found out. If you use the absolute value for the signal intensity, then there's no correlation whatsoever. However, if you use the stock ratio and normalize it by doing that ratio, then you can have almost a linear relationship. So when I tell Raja in India that my machine Siemens, the C-stock is 0.6, if he does the same exact patient in India, using the GE and use that ratio, he'll come up with the same number. So now we're able to first use a similar language in terms of quantifying the signal, and 2, use it across different platforms of machines, if you will. The next step was for us is, okay, this is a lot of manual work, if you will, to calculate the signal intensity. Can we create a semi-quantitative one? And what we did is right here, example here of the stock ratio. You could see the basal-tip aneurysm being painted, and you can tell you hear the different values, but you would take 4 points in the pituitary stalk and then you average them and then create the ratio. So can we use a semi-automated protocol, if you will, to quantify this? And this is what we're working on. What we do here is we take the aneurysm, we enlarge approximately 6 times, and then we paint, if you will, the wall if we can see it, and then we apply the heat map, and then after I subtract it. And you could see right here, the aneurysm wall have different colors. And based on this different colors, you could see how the intensity of the signal using the gadolinium. And we did that on different aneurysm, if you will, and you can see here, you can depict semi-automatically the signal intensity instead of using point by point. More of that. So what we came to a conclusion on that one is the pituitary stalk is the most suitable way to reference the signal intensity, and we can use the semi-automated way to calculate that. Now, as Raja mentioned, that I did a lot of work on aspirin, and we showed both in human and in animals that aspirin decreased the risk of aneurysm rupture by decreasing inflammation. So we wanted to see if we give aspirin, does the signal, if we think it's indicative of inflammation, is a surrogate, if you will, a surrogate biomarker for inflammation, can we modify and modulate that signal? So what we did is we did the aspirin. Again, from our registry, we have retrospective, we went back and retrospectively looked at it, and we used a cutoff here, 0.6, and we defined use of aspirin as 81 milligram for greater than 6 months. And we use that on evaluating 80 patients. This is a demographics. And when we found out that using multivariate analysis, if you will, that if you take aspirin, then the aspirin decrease the signal intensity in the aneurysm wall. Size, if you have greater than 7 millimeter, increases signal intensity. The location, typical of the ISUA and the UCAS study, showed that the posterior fossa circulation can increase the aneurysm ratio. And also the age. The older the patient, the higher signal. We think that because atherosclerotic variable. But again, there's different ways of modulating the signal. And we came from that this signal is truly a surrogate for inflammation because you can modulate that signal because you're modulating the inflammation with using aspirin. Now, prospectively, have any been done work on that to predict risk of rupture? And now we have a group from Netherlands and France. They all showed that you can use that enhancement to predict future rupture or growth of aneurysm. And the most compelling evidence that is not the positive enhancement, it's the negative enhancement. Meaning, if the aneurysm does not enhance, then the aneurysm risk of rupture is almost 0. And that's based on the negative predictive value from all these 3 studies showed that 97% negative predictive value. So now we change in our trajectory, and instead of saying, okay, because enhancement could predict rupture or unstable, and we still kind of figuring out. But if it's negative enhancement, then we know, as I said, with 97% certainty that it's stable aneurysm. Also, our colleagues from Netherlands, they showed that really the enhancement of this is due to low flow and mainly low wall shear stress. So we did that and ourselves, and we collaborated with a group in Germany and also here in the United States. And this is an ACOM aneurysm, and you can see here is a daughter sac. And that daughter sac enhanced on the vessel wall imaging, but when we did that computational fluid dynamics, it corresponded to low wall shear stress. This is kind of, again, more. You can see here's the 3D for the daughter sac. It enhances focal enhancement. And you can see here, the third panel and C is the low wall shear stress. So we have a lot of studies. We're going to publish it. It's coming out in AGNR. And also there's a group from Germany and also from Netherlands are published already and show that the enhancements in the vessel in the aneurysm is really truly not a surrogate, a biomarker for low wall shear stress. So low wall shear stress is indicative of an enhancement. And there's a lot of literature that shows that low shear wall stress enhancement lead to inflammation. So that's how the link between those things. To further that, as a group in Japan and our group also chose a rabbit model of cerebral aneurysms where we do elastase, and we did the vessel wall imaging and correlated the enhancement, if you will, with the inflammation. And you can see here that the enhancement correlate with inflammatory cells. And also we, finally, but not least, this paper just submitted to the stroke. We took about 25 patients. We did complete CFD on these patients. And so we did aneurysm shape indices like the aspect ratio, the non-sphericity index. And also we collected aneurysm, blood from inside the aneurysm wall, from inside the aneurysm sac, and analyzed it. We kind of published on that and established this protocol. And we looked at about 50 different variables. And what we found out that the enhancement correlate with the aneurysm area, the aneurysm volume, the maximum diameter, the low wall shear stress, the non-sphericity index, but also we noted that interleukin 10. So the aneurysm that does not enhance have a lot of interleukin 10, significantly more. And interleukin 10 is anti-inflammatory. So this is all kind of fit is one picture. This, we did a 360, if you will, of that. So where do we go from there? I shared with you a lot of data that shows promise that this technique can be used in differentiating, if you will, stable from unstable aneurysms. There's a lot of work to be done, but the next step is, I think, need to be validated prospectively in a larger clinical trial. So what we want to do is we want to use the C-stock ratio, the cutoff, which is greater than 0.5, as a surrogate, again, not the biomarker, as a surrogate biomarker for stability. Again, the enhancement is a biomarker of low wall shear stress, and low wall shear stress is a biomarker for inflammation. Therefore, the vessel wall imaging is a surrogate biomarker for inflammation and instability. So we presented this to our NIH, and now we have a trial called Imaging U. It's in the planning, and we're doing several centers here in the United States, Canada, England, and New Zealand. And the idea is to image these patients and monitor them prospectively and see if any of these aneurysms will proceed to grow or rupture, and correlate that with enhancement. So we'll keep you guys updated that, but this is an opportunity for people around the country, I mean, around the globe, if you will, to adapt this and do their own work and add some of their experiences and some of their scientific work to either validate or non-validate. At the end of the day, you have to be very objective, and you have to accept what the trials and the experiments show. If it validated further, then yay, we can have found the holy grail. If not, then we're going to continue to, evolve and work on different techniques. With that, I conclude my discussion, and I thank all people for taking their time in their evening to listen to my talk. Thank you.
Thank you very much, Professor David. That was an excellent talk, and we learned a lot from these newer modalities of imaging. May I please request Professor Kimura to say his expert comments?
Thank you, Professor David. So thank you for your excellent presentation. I learned a lot from your lecture, not only your paper. Yeah. So, but I have great concern about your research in cerebral imaging. So, but I still, this is my first question is just after you mentioned in your presentation the aneurysm ruptured aneurysm have strongly wall enhancement on the cerebral imaging, but just we watch the enhancement just after the change of the aneurysm or after the rupture. So we should know, we should watch the just before the rupture, aneurysm rupture, the aneurysm actually has a wall enhancement or not. We have to know, we have to watch just before the aneurysm rupture. So all your data was shown in the ruptured aneurysm was after the aneurysm rupture. So as you know, the aneurysm rupture, and just after the aneurysm rupture, the shape may be changed, and of course around surrounding the tissue maybe some inflammation occur. Naturally, the aneurysm wall enhancement may occur. So how do you explain about the situation?
So I think I respectfully disagree with you. The first work, you are correct. The first work was done with only ruptured aneurysms.
Mm-hmm.
That's absolutely. This is where the observation from Matuk and El-Jalali, Mariam El-Jalali showed in 2013 and 14. Their work was case series, a few cases on ruptured aneurysm. Now, all the work since 2015 and further is on unruptured aneurysms.
Unruptured.
Mm-hmm. Yeah, completely unruptured aneurysms. And the data I showed to you already, my data is all unruptured aneurysms. That's number one. Number two is all the aneurysms, the tissue we collected, that's all unruptured aneurysms. And that's published in Stroke. So if you read the articles and be familiar with the topic, you know, all that, there's three groups, the University of Hiroshima, there's one from Netherlands and us, that the aneurysm wall tissue, that's all done from non-ruptured. And we correlated that with inflammation. We correlated the enhancement with the inflammatory cells in non-ruptured aneurysms. That's number one. Number two is I showed you there's a rabbit model, animal model, that these aneurysms non-ruptured, we just treated them with elastase, and some of them were sham, we just say nothing. Some of them had saline, some with elastase, and some with elastase and LPS to exaggerate the inflammation. And as you see, because of that, the inflammatory cells kind of is stepwise higher. And all the intensity of that showed that there is correlation. So that's that. The third step, if you will, that's why if you've read the literature and become familiar with it, there's three groups already now showed that unruptured aneurysm that followed prospectively. Yep. One from, two actually from France with 200 aneurysms. There were one published in AGNR, published in Stroke, and the one I showed from Netherlands. And these are unruptured aneurysms that followed prospectively. And again, showed that the enhancement correlated well with the predicting, if you will, growth or rupture. But as I said, the most important from those prospective studies was if the aneurysm did not enhance, then there's 97% chance that this aneurysm will be stable. So that's where the negative predictive value.
Yeah.
So that's again, originally started in the beginning as ruptured, but all the work we've done so far and all that analysis, whether in tissue analysis, animal studies, CFDs, all that was done in non-ruptured aneurysm.
So my second question is, usually the aneurysm rupture may occur at the thin walled region, as you know, it's well accepted common situation. So thin walled region can be easily ruptured than the thick walled region. However, as you mentioned in your presentation, thick walled region may be easier to be enhanced by the thin than the thin walled region.
I agree with you.
Yeah.
This is what we did when we did our analysis. But remember, so did you see that that big aneurysm that enhanced, if I can go back the slide, that shows at the base there was a daughter sac. Mm-hmm. So again, by doing the electron microscopy, as again I said, there is no gadolinium goes into the wall. What we saying specifically that the enhancement that we see at the interface between the aneurysm wall and the blood is indicative of low wall shear stress.
Low wall shear.
So the daughter sac, as you know, and you're familiar with this work, has definitely low wall shear stress. And because of that, low wall shear stress, and it's well established both in human pathology and histopathology, and in animals and in vitro, low wall shear stress is a biomarker for inflammation. So again, vessel wall imaging is not a direct biomarker for inflammation. It's a biomarker for low wall shear stress, which low wall shear stress is a biomarker for inflammation. Therefore, we are very specific with our wording, very specific. And that's what I have, everybody gets from me, that vessel wall imaging is not a biomarker for inflammation. It's a surrogate biomarker for inflammation.
On that specific note, I would like to ask Professor Hasan that, as you said, that low wall shear stress is a marker of inflammation, and it has also been noted as a marker of growth and rupture. But there is also another theory that says that high wall shear stress is also a marker for growth and rupture.
No, this is where we are.
There are several authors who have written this, even from one article which has been authored by Professor Alberto Faletti, which has come from Bentane, from Professor Yoko Kato's place. They have mentioned this specific point that both low as well as high wall shear stress has been correlated with growth and rupture.
Let me help you with this, Raja. What we believe, and also from Buffalo, that high shear stress is the culprit of aneurysm formation. And low wall shear stress is culprit of growth and rupture. So they're together, work together. You need the high shear stress to form the aneurysm, and that's where and then the low wall shear to, again, there's not like a clear cut, as you will know, there is an interface and things, but this is what we show from the enhancement, and there's a lot of controversy, but I think people are coming closer to understanding that, high wall shear stress is needed. And I think Akoye from Japan showed that this will lead to increase in COX-2 and aneurysm formation, but the low shear wall stress is for inflammation. Again, there's a lot of work to be done and delineating that, and there's not a complete cutoff. But you cannot say, what I'm trying to say here, you cannot say that the vessel wall imaging is a biomarker of inflammation. It's not. It's not a direct. It's a surrogate, if you will. Something intermediate in the middle.
My comment. So wall shear stress, yes, low wall shear stress make it means the blood stagnation, the focal blood stagnation. Usually, the blood stagnation occurs, the monocyte and the white blood cells infiltration occur, and finally, some published data show the aneurysm wall thickness occur. So that's why the low wall shear stress causes to aneurysm wall thickness. On the other hand, high wall shear stress may also, as I mentioned, cause to aneurysm initiation also, and it causes aneurysm wall depression, and finally cause to the aneurysm wall thinning. So it's my opinion, but some also published data shows the high wall stress cause to aneurysm wall thickness, thinning. On the other hand, low wall stress cause to aneurysm wall thickness. So it should be
balanced. Maybe please open this platform for discussion. May I please call upon Professor Hirotoshi Sano sensei?
Hello, yes. Yeah, but I am now driving, so that's difficult to say. But that's a very important point of the for treatment of the unruptured aneurysm. But doctor, do you recommend to, if the patient has the aneurysm, taking the take the aspirin. And in Japan, and someone is saying that it's recommend to taking the statin and also elastase. How do you think about that?
Again, my friend, I mean, I focus mainly on aspirin.
Aspirin, but statin is also
Statin.
statin is yeah.
Statin.
Yeah, I think there's mixed data out there about the statin. Some showed that the statin is effective, and some showed no significant difference. But I think both aspirin and remember, I'm not only recommending aspirin. When we did that, we wanted to show that before, the only way you can treat aneurysm was to clip or coil or watch. But we're opening a gate and a frontier that you can actually change the natural history of aneurysm by using medical agent, whether it's aspirin or whether it's something in the future better. I think the work need to be done. Like Rajesh could come up with you do a work and find something more effective than aspirin, more effective than statin, maybe COX-2 inhibitor, specifically like Celebrex or something. So the work need to be more. This is only we're in our infancy. What we're doing here is it's really is in its infancy, and we need to kind of think objectively and think we're no one better than neurosurgeons who have access to this tissue, access to a patient, to lead the group, if you will, to pioneer this. So if it's statin, if you in Japan that statin is effective, I think people should use that. If aspirin, I mean, I know in the Asian population, you cannot use higher dose of aspirin, 325, because it's stomach ulcers and everything. So we try to go to the lower dose. But I think I think both agents could work on these aneurysms and change the natural history.
Professor Mohan Sharma.
It's a great presentation, Professor Hasan. My question to Professor Hasan is the philosophy eventually preventing the rupture of the aneurysm, or do you catch them before they rupture so that you do either clip or coil? What is the main philosophy?
That's a very good question, my friend. In the United States, specifically in the United States, again, please understand this is on the United States.
Okay.
Every time you complain of a headache, you get an MRI and CAT scan. And because of that, the number of diagnosed aneurysms have gone off the roof, increased. Okay. So someone comes in to you, a 73-year-old, didn't eat, had headache. You image them, they have 6 millimeter, 5 millimeter aneurysm. What are you gonna do? Are you gonna treat? 73. Are you gonna treat? Are you gonna watch? Now, medicine has advanced age very well. So what we suggest in the philosophy is, because of the rapid increase of numbers, we need to differentiate which one is we're going to rupture, which one is not. That 73-year-old, she said, I tell her, no, you're old. He said, what? You're old? I'm not old. I can live to 100. So, I mean, you offend that patient. And the endovascular technique now is very effective. Not only that, in the United States here, as a neurosurgeon, we're not like in other countries around the world, you pay salary. Here, the more you clip, the more you coil, the more you make money. So now 5 millimeter, 4 millimeter aneurysm is being treated, whether you're 80 or you're 20. So I think that's where the philosophy is. We try to more empower both the patient and the physician to make the accurate decisions. Another problem in the United States is you come in, you're 73-year-old, you have 6 millimeter aneurysm, you tell the patient I saw data, and then the patient goes a year later, the aneurysm rupture. It could happen, very small, but it could happen. Guess what? The family will sue you for $20 million. You didn't treat my patient. So this is where we at. We empowering the patient and the physician at the same time to be objectively use a way of managing these patients.
May I please call upon Professor Ajit Sinha?
Yeah, good evening. It was really a nice presentation. My question is that could you come across some patient, or you did the scan of a patient who didn't come with history of headache? Because my point is that you know, tolerance to the headache can be different with different patients. So some patients with some sentinel bleeds, they might have also been included in this, which were actually the, you know, micro ruptures of the aneurysm. That's a question number one. And number two, how long was the follow-up of any such patient with enhancing aneurysm wall without any clipping or coiling?
So for your first question, you are correct, my friend. You're very correct. I live in the state of Iowa, and the state of Iowa, there's a lot of farmers, and the farmers are very tough. You know, they don't complain unless they really, you know, they're hurt. So when we did the QSM, we found that about 50% of the patient, they were positive on the wall, microbleed. And so it's like, you know, the technique is not, you know, it's not good. But we went back and asked this patient, it's like, hey, in the past year or 2 years, not like the immediate past, in the past year or 2 years, have you had really bad headache? Oh yeah, doc, since you said that, yeah, I had that 2 years ago or a year ago. So you are absolutely correct. Yeah. That does, you know, at one point the event happened and the patient either, because remember, it's a microbleed, it's not everywhere. So the aneurysm wall was leaky and seeped. And whoever clipped the aneurysms, a lot of times, sometimes when we clip aneurysms, that unruptured. Some of them, when you dissect it, you can see it's the arachnoid is really nice. You can open, there's nothing. And sometimes there's part of the aneurysm is really scarred in the brain tissue. And you really have to do subpale dissection to free it out. So I think those areas, if you will, those are micro bled or seeped, if you will. But not enough, if you will, to cause the subarachnoid hemorrhage.
Second question was like, how long was the follow-up of any patient which has not been clipped or coiled, where there was an enhancement of the wall, aneurysm wall, and you know, maybe 1 year, 2 years later, did you see any change in the pattern of enhancement?
Correct. We have followed patient for 2 years so far, and also the Netherlands and the French people about 24 months average. And yes, we saw that people, some of the patients, it's about, I would say, in the small aneurysm. We did the small aneurysm. Again, we're only following prospectively the ones below 7 millimeter. And we found about 4% to 5% of these patients that did not enhance went in to enhance. And then when we did the volume measurement, we did not the size, volume measurement, we think because it's accurate and non-sphericity index, we found out those people did have change in the volume. So that enhancement, the change in enhancement from non-enhancement to enhancement is indicative of changes in the aneurysm, one way or another. We did not see much of patient changing from, if you take the group with the aspirin, if you discount the people with the aspirin and the statin out and did not have change in medication, we did not see people that were enhanced to go non-enhanced.
I'm sorry I joined late, but the discussion is quite active and interesting. I would like to ask Professor Hasan that did you find any difference when you compared the aneurysms from each segments, and could you find any difference in parophthalmic segment aneurysms? At the same time, the blister aneurysm, how did they behave in your study?
So that's a good question. If you're talking specifically about aneurysm wall tissue, you remember when we put the clip, we only can cut the dome. So there's already bias there because you're not getting the whole aneurysm. And so when we did that, we only chose the aneurysm that circumferentially enhanced, completely enhanced the wall. So we have no bias. So the aneurysm that has focal enhancement, we were unable to accurately depict the changes because again, you may cut a wall part of the aneurysm that doesn't enhance. So that's where we are, the limitation, if you will, of this correlating histology to enhancement. Now, blister aneurysms, we have not done any pathology because, you know, I'm blister aneurysm, technically, whether open or endovascular, are very challenging. And so I don't mess around with them. If I see blister aneurysm, I treat, whether with pipeline, if it's unruptured, or I use the wrapping technique and the clip that Spetzler and Dan Barrow uses. So I have not focused on that, my friend. I'm sorry on that.
But about the ophthalmic segment, did you find any difference compared to the other aneurysms like MCA or ECOM aneurysms?
In terms of enhancement?
Yeah.
Yes, we found differences. Actually, the enhancement correlated with ACOM aneurysms, PCOM, and basilar. Did not correlate with paraophthalmic.
Professor Kimura, any closing comments from you?
Raja, let me just say one more thing.
Yeah, please.
Colleague, please, my discussion today is not to be dogmatic or anything. My discussion today is with you and for all the people, especially the young neurosurgeon, is we need to look beyond what we have techniques. And we need to be technically good. We have to be technically good in clipping, coiling. We have to be, we're the best suited to treat these aneurysms. But we also have to focus on science. The way we advance our knowledge is by doing research. And we have to be open-minded. This technique could be wrong, may not, but at least we're doing the research and advancing the science. That's my message today for everybody. Not this vessel wall imaging is predictive or not, is we need to do the work and the footwork and do the science. Thank you.
True. And one thing, your technique should hold a promise for multiple aneurysms also, because
Right.
of course there is discordance of 16% among the best, like which one has ruptured. So this should hold promise for in such situations also, right? I think you might have some experience in that also.
Yeah.
Have you examined that?
Yeah, we've done that, and actually we an aneurysm that comes in, and surprisingly enough, we had a patient that came in had PCOM aneurysm 8 millimeter and an MCA aneurysm that's about 4 millimeter, and by the ISO and everything, we should treat the PCOM, but actually the blood was more toward the MCA and the enhancement was toward the MCA. So we treated the 4 millimeter before we treated the large aneurysm. So again, it could be helpful. The verdict is out. Professor Kimura said that there's, controversy. And I think this is where our work together as a team around the globe try to either validate it or disqualify.
Yeah, with that, I think we'll wind up this session. So on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I sincerely thank the speaker, Professor David Hasan, and the chair, Professor Hidehito Kimura, for coming here and giving us insights into this novel imaging technology about detecting instability in unruptured aneurysms. We learned a lot from today. We hope to have your continued support for the educational activities of the ACNS. So until next Saturday, it's all bye-bye from all of us.